I'm hoping the live streaming is on now. Let's start. So, good afternoon and welcome to the Portsmouth CCG Governing Board meeting in public. I'm Dr. Elizabeth Fellows and Chair of the Governing Board. We're meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available on the website. Today's meeting is being recorded so that in the event of a failure of technology, it will continue and will be uploaded to the website as soon as possible. Bookmarks have been added to your papers to make it easy to find the different papers. Members, you're asked to keep your cameras on wherever possible, but mute your microphones unless you're called to speak. Please only use the raised hand or chat functions to indicate you wish to speak. Any typed comments cannot be viewed by the members of the public and they confuse me. I will also ask all of you in turn to state your full name and role. So I will go down my list, and I am aware we are still expecting a couple of people to come in. Technology. So Bernie.
Thank you, Elizabeth. It's Bernie Allen. I'm the Deputy Director of Planning Analytics for Portsmouth CCG.
Helen.
Thank you, Elizabeth. I'm Helen Atkinson and I'm the Director of Public Health for Portsmouth.
Karen.
Hi, Elizabeth. I'm the Governing Board Nurse for Portsmouth CCG.
Jane.
Jane Collis, Business Services.
Margaret.
Margaret Geary, lay member.
Hayden.
Afternoon, everybody. I'm Hayden Jones, Assistant Director for Children across the CCG and the local authority. And this week is my turn to cover the DCS role, pending an interim.
Thank you and welcome, Hayden. It's good to have you to your first board meeting.
Thank you.
Justina.
Good afternoon. I'm Justina Jeffs, Head of Governance for the CCG.
Graham.
Good afternoon, everyone. I'm Graham Love, lay member.
Maggie.
Good afternoon. I'm Maggie McIsaac. I'm the Accountable Officer.
Carsten.
Good afternoon. My name is Carsten Schaff. I'm a GP and one of the clinical execs at Portsmouth CCG.
Linda.
Good afternoon. I'm Dr. Linda Colley, GP and Clinical Leader for Health and Care Portsmouth.
Jackie.
Hello, I'm Jackie Powell, one of the lay members. Thank you.
Dave.
Good afternoon, David Scarborough. I'm the CCG Practice Management Representative.
Andy.
Good afternoon, Andy Sylvester, lay member.
Michelle.
Hi, I'm Michelle Spandley. I'm Chief Finance Officer for Portsmouth CCG.
Tawinda.
Hello, I'm Tawinda Uppal. I'm Secondary Care Consultant.
And David.
Hello, I'm David Williams. I'm the Chief Executive for Portsmouth City Council and Executive Lead for Health and Care Portsmouth.
Thank you. Now, I missed out James Harris. I am assuming, James, you are on for Democratic Services. Am I right? Yes.
Yes. Yes, he is. It's just to facilitate the recording. Yeah.
Yeah, I was just making sure I hadn't missed someone. And Joe.
Yeah. Hi, I'm Jo York, Managing Director for Health and Care Portsmouth.
You dropped off my list, Joe. Do apologise.
No worries.
Right, and we have apologies from Dr. Simon Simonian and Dr. Nick Moore. Any others, Jane?
Just that Anthony Harper won't be attending to present the item.
Right.
Be Hayden. Okay.
No, but Hayden's doing that. That's fine. Lovely. Okay, so moving on to item 2 on the agenda, register and declarations of interest. I understand, Linda, you want to add something verbally?
Yes, I've got a declaration for item 9, please, and I need to update the register. I can pass that to Jane.
Okay. So, so when it comes to item 9, the nature of your interest, we would welcome your discussion, but if I don't believe there is any definite decision to be made, so we should be okay on that.
I believe it's just a strategy, Elizabeth.
It's just a strategy, isn't it, Hayden? So no decision. So you're welcome to join in. And Jackie?
Oh, yeah, probably to make a declare for item 9 as well, as I'm a young person's counsellor for other organisations. So just so it's open.
Lovely. Thank you very much. Has anyone else got any other declarations to either add or highlight? Good. I will take that as no, and we'll make sure Linda's new conflict is or declaration of interest is added to the register. Thank you. So minutes and actions of the previous meeting. Anyone got any comments or corrections on the minutes from last meeting, which was on the 21st of July? Jackie?
I think it's a tiny correction on under 8, quality and safeguarding, the first bullet point regarding Solent and BPAS. And the sentence reads, and the service were not seeing patients face to face and were risk assessing. Should that be were not risk assessing? I thought that was part of the issue.
They were risk assessing over the telephone, not face to face. So they were making a risk assessment, but it wasn't a face to face one, I think. I don't know whether anyone else wants to comment on that.
I think that's correct, Elizabeth. It's Karen. I think that's correct.
Thank you.
Yeah. Do we need to make a little tweak then to say not for under 18s face to face, we're not assessing, but were for others or something like that?
No, they were assessing risk, but it's very much harder to do on the telephone than face to face. Bearing in mind, you cannot examine someone over the telephone, and it's that bit of that risk assessment that was missing when they're doing them remotely.
Okay.
So they were making a risk assessment, but it was just a much harder one to perform and was more open to errors, I think, is the impact of that. Well, I'll take it away and have a look at it afterwards and just see if we need to tweak it.
Right, thank you.
Any other questions or comments, corrections? So are people happy to approve those minutes? Various shaking of nodding of heads rather than shaking. Lovely. So item 3B, we've got the summary of actions, which my computer goes any slower, it'll be going backwards. Oh, for goodness sake. So, summary of actions are all complete. Are people content that these have been done?
Agreed.
Thank you. It's nice to have some response. Right, so we can close those all down. And then moving on, for once, Helen, I'm not going to forget you. We have got a verbal update on the state of play for Health and Care Portsmouth from Helen Atkinson. So over to you, Helen.
Thank you, Elizabeth. I'm just going to share the slides, which I will talk through. Apologies, it is loading.
I'm not the only one with slow Wi-Fi then.
So I'm going to cover, hopefully you can see those slides now. I'm going to cover a bit on vaccination uptake for Portsmouth, infections with so the infection rates with comparators, and then quickly cover hospitalisations and deaths. So just to show here the vaccination uptake, we put it as a tree so that you can see it against breakdowns of age groups. Overall, the percentage of our population who've had their first dose is 76.9, and then both doses is 68.6. And you can see from the tree on the left hand side, we've got really, really good uptake in our older age groups. And also as we come down there, we are still really very much focusing. This is obviously what we call an evergreen offer. So we're still really doing a lot of targeted work, focusing on trying to get uptake rates improved on particularly our 20 to 40-year-old age group, but specifically targeting communities where we know that we've got lower uptake. So obviously pregnant women, some of our BAME communities, and also some of our other inequalities groups. Would like to just point out though, because obviously I know there's some of our younger age group have only just about to be offered. And although this slide breaks it down from 16 to 19, if we actually look, because we've just got the broken down data, I'm sorry it's not on this slide, but if we take our 18 to 19-year-olds, we've got really good uptake in our males at 67% and female at 73%. So I really wanted to mention that, because I think there's sometimes the feel that some of our younger population are not getting vaccinated. And even our 16 to 17-year-olds, we've got 52% uptake in males and 57% in females, and they've only just recently been offered the vaccination anyway. And of course you'll have heard the announcement this week from the Prime Minister that we will be offering lots of planning work in the NHS vaccination cell for the 12 to 15-year-old healthy children to be offered the vaccination through the schools programme, which is really good news. And so I just thought I would mention the specific ages. Then if we quickly just look at our infections, their rates, and this is our 7-day rolling average of cases in Portsmouth, you'll see we've had 752 new cases in the last 7 days. But importantly, you'll see that the spike line is coming down. And I'm very pleased to be able to say today, because we have had recently an increase in cases, that is now stabilising and starting to drop. However, it's important to note that we are still expecting a peak of cases or an increase in cases towards the end of September, October, mainly due to obviously moving into the autumn and with schools returning. If we then just quickly look at our spark lines again, you'll see that this is our comparator, and we've got data there for the whole of Hampshire and Isle of Wight, with Southampton, Hampshire and the Isle of Wight in there as well. The good news is that generally, even in Portsmouth now, that the spark lines are all reducing there. And if we actually take, I think, this slide, which is a bit easier to see the comparators, on the left-hand side, you will see there the map of England, where the areas where much higher rate of infection there in the deep reds and the reds. And you'll see mainly around the areas, mainly around the Midlands and the northeast, northwest. It's quite good to see there that Cornwall and Devon have gone back to amber and yellow, because they're quite close to us, because they've actually had quite a high peak and have been in the red over the last few weeks, particularly following Boardmasters, where there was quite a spike in infections. And I'm pleased to be able to say that obviously in Portsmouth we've just had the Victorious Festival, and we've been closely looking at the data, and we are not seeing a spike in cases following the Victorious Festival, and in fact actually our infection rate is lower the week after than the week previous to the festival, and we are following all the positives and the post-COVID coincidences that are linked to the festival, but it's all looking really good at the moment. And then you'll also see there that just put them down as arrows in the change in the last 7 days. It's good news both for the South East, for England, but also for all of our local authorities in Hampshire and Isle of Wight. who are all coming down in terms of the infection rates. And there's a couple of the comparators there. So we are still in Portsmouth slightly higher than Southampton, Hampshire and Isle of Wight, but all going in the right direction. And you'll see there Blackpool and the city of Kingston upon Hull as two examples where they're still seeing in the north, east, northwest high levels of infection. And if we just have a look at our age bands or breakdown of cases across our age bands, you'll see there that all of the age breakdowns, the rates are falling across all age bands apart from the 0 to 14s, and people won't be surprised to hear that. And if we actually then break that down into our children and young people's age band specifically, you'll see that it is basically the secondary school age group where we're seeing higher or infection rate not reducing at this point. And it's important to note, obviously, that schools, it's the second week back and there's an awful lot of testing happening in schools, and and I won't, because Hayden will be possibly I don't want to take Hayden's role, because but it's important to say that we've all been working very, very closely with Hayden's team to ensure that we are working with schools to support them to manage the outbreaks. We are seeing a number of cases increase in schools and a few outbreaks occurring, which was as expected. Then if we move on, because this is the good news, of course, is that we know that we are seeing cases in the community and spread in the community, obviously, now that we are all meeting up more and the restrictions have been eased. But we are very, very aware at this meeting that, of course, the NHS is under severe pressures at the moment across the country, but in the main, at this point in time, they are not COVID-related pressures, and we're seeing admissions remaining fairly stable, as well as ICU admissions into ICU through COVID. So that's staying fairly stable, but lots of pressure in the NHS. We are seeing a lot of other pressures, not only in terms of obviously catching up with activity, but also what we are still seeing is other viruses that we would perhaps normally see in the winter, creating some pressures now in the summer, which is fairly unusual, but we recognise that it's going to be a busy autumn and winter. I mentioned because, of course, the CMO also published the autumn and winter plan for COVID, for managing COVID over the next few months yesterday. And then finally, I will just end on deaths, which again is a better picture in that we've not seen any deaths in the last 7 days overall. And if you look at the chart, obviously we've seen a lot fewer deaths in recent months, and certainly, and which is my final slide, we are seeing less than we would normally expect, so no excess deaths due to COVID currently, so we're actually seeing less deaths than we would have expected to see in the previous 5 years averages. So I'll end there and stop sharing the slides. Thank you, Elizabeth.
Thank you very much. So, have you got questions? And Hayden, did you want to talk any more about the school testing programme?
Yeah, I mean, generally, I think obviously the secondary school heads are just trying to get their heads around the 12 to 15 vaccination programme. So that's going to be something that our secondary heads are very keen on. The conversations we've had with schools since schools reopening is, I think there's kind of mixed practice in schools is what we're seeing. So we're seeing some schools that are still retaining a level of social distancing and the use of bubbles, but some schools less so. So we're seeing a kind of variation in practice. But we have seen, as Helen said, a small number of outbreaks in a number of schools already. I suspect we'll see some more over the next few weeks. Generally, our schools have been pretty good at engaging with Helen and public health colleagues around infection control measures. But it is a busy time for our school colleagues at the moment. It doesn't feel like a normal September. I think that's fair to say.
Lovely, thank you. Are there any other questions or comments? No? Oh, Jackie.
Hello, it was one link to the schools, so maybe Hayden might be able to help. It's how are things going at the universities? Are we anticipating that they'll also be having some kind of social distancing bubbles, this sort of thing? Or is it, as in other areas I've heard, you just go back? And another question, just a bottom on the end, is around care homes and how vaccinations are going on there.
Helen, do you want to pick up the university bit through the Public Health Board?
Yes, so we've been working very closely through the Health Protection Board, which Hayden's a member of, with the university. So one of the things that is going to be happening, and they've got very much got their risk assessments and their COVID prevention plans in place. But obviously the legislation has changed, the regulations have eased, so they will be going back to face-to-face learning, but their big lectures, the work they've done is that their big lecture will be online, but they will be doing their seminars face-to-face, but still with very much with COVID safety measures in place. And what I've been most impressed with the university is the testing and vaccination work. So they've been working with Solent, and in the Freshers Week and the registration week, they will be having daily pop-ups that Solent are providing to encourage those students that haven't already been vaccinated to have their first vaccination, or indeed some of them might be ready for their second vaccination now. And they have been undertaking regular testing. In fact, they've been identified nationally as an exemplar in terms of the testing regime that they've had in place. So lots of good work with them, and they've worked very closely with their student union to support students, making the right choices. So I think they've done a really, really good job. And then is Jo going to take the care homes? Yeah.
Yeah, I can take the care homes. So I think we were really successful in the first instances back in December, January of vaccinating our care homes. PCNs worked really well together, going out to the homes to deliver those vaccinations. That I think we had 100% coverage, or very close to it. And what they're now doing is building on that learning to think about how they do the flu vaccinations as a PCN rather than individual practices going in. So being able to go in once to the care homes, and also thinking about the boosters. I think some of that we haven't quite got the detail that we need to start actively planning that at the moment around when we'll get the supplies in of both the flu and the COVID booster, but the practices are designing the approach, certainly.
Great. And could I just ask, I forgot to add at the end, but in terms of care home workers, have they been able to get vaccinated?
Yes.
Are we insisting on it, or what's the protocol?
Sorry, we did something on this yesterday. Helen, if you've got those numbers, just bear with me. I will get them.
We can put the numbers up. We did have them yesterday.
Yeah.
Just to say, though, that we've got very, very, I think my independent view is we've got pretty good levels of uptake in vaccination in our care home staff across, so much higher than in some other areas of the country. So we're well into, I want to say it's the 90%. So there's only a few last care workers that currently the quality team and Andy, as the DAS in the council team, are working on to ensure that they've had vaccination, because obviously the time now is so it's the timeline now that you have to have had your first vaccination to have your second before the mandatory vaccination rules come in. And also, just to say, Jack, and you also asked about testing, and testing regime in care homes hasn't changed. It's still there. So it's the national testing regime that is in all of our care homes, which is weekly testing for residents and staff, both in terms of PCR and in lateral flow tests.
Thank you.
Yeah.
That's incredibly helpful.
And that's a similar position when we look at the other care homes across the city as well. For those vaccination figures, they're tiny numbers, and our teams are working with them. And some people have now agreed or have had their vaccination booked. So the numbers who are choosing not to are very, very small, really tiny.
That's lovely to hear. Thank you. And well done for all the hard work to everybody.
Thank you.
Thank you very much. Right, and thank you for that update. It is good news again, and we hope that we stay on a downward trend, and that the blip that is forecast for October perhaps doesn't arrive. Modelling has been wrong in the past, so fingers crossed. Right, we will move on to the executive report from Jo, please. Item 5.
Yeah, thank you. And there were just a few points that I wanted to highlight to the board and bring to your attention. The first is in relation to the piece of the report relating to the Primary Care Commissioning Committee. Just wanted to give you an update around the Guildhall Walk practice and to say that we have successfully transferred all of those patients now, and we're just working with the provider of the Guildhall Walk practice, PPG, to do the close down of that building, but all the patients have transferred successfully. The Safe Space service has moved into the civic offices. That's the late in the evening, Friday and Saturday evening ambulance service that supports people with in the nighttime economy. So that's moving into the civic offices, with a view to that being a long-term home, but very much trialling that to see if that works. But in terms of a location, it's perfect. And then we're continuing to work with Hampshire, Southampton and the Isle of Wight CCG colleagues on reutilising the special allocation service, which is for some of our most complex patients, very, very small numbers, which PPG also ran and will continue to run. And that's a service that runs across Hampshire and Southampton and Portsmouth. So we're continuing to develop that as well, so that there's no issues in continuity of provision. The autism contract we have now extended for further 12 months. So the questions that the board had previously have been answered, and the executive committee satisfied that those answers have been satisfactory. So we've now signed that contract. And then the other thing I wanted to raise with you is just about the Joint Commissioning Board with Portsmouth City Council. You'll be aware of some of the governance work that we've been doing. We've been looking at that with and getting legal advice with that on our colleagues in Bevan, Britain. We're re-establishing that committee to start from the early October, and we had an informal meeting of that with other partners earlier this month, and we'll be inviting provider partners to that committee to be involved in the decision making around whether that's business cases, but also where we have that joint funding with the City Council. The committee will meet formally again in October, and we'll look and review the work we've been doing to update our Section 75s with the City Council, and in line with work other places in Hampshire and the Isle of Wight are doing, so Hampshire and Southampton, for example, to really look at how we can go further with that integration and those pooled fund arrangements between health and the City Council. So that will start to happen again from October. And then finally, just to raise awareness to the PricewaterhouseCoopers governance review, which was undertaken earlier this year. The audit committee has been reviewing the actions and our progress against those actions, and Dr. Elizabeth Fellows has written to NHSEI with an update on those actions, the majority of which have now been completed, and some are still in progress where they had longer run-in times. So they were the things I just wanted to highlight. Thank you.
Thank you very much. People got questions or comments for Jo? Graham.
Thanks, Elizabeth. Just to say good news on the safe space, Jo, so that's a positive sign. Obviously, be kind of interested to hear how that goes, but obviously it sounds positive. I just wanted to say I noted the comments around the practice websites, and Healthwatch are going to do a further piece of work, but would be interested when they have done just to pick up some of that, because I certainly get very mixed reports from people about the quality and how well they're updated. So I think it would be interesting to pick up their further piece of work and see if there's things we can do to help improve that.
Yeah, I'm sure there are, and I think you'll be aware that we've recruited to the vacancy that we had in the Health and Care Portsmouth communications team. So Hayley Cook joined us last week, and we're recruiting to another post to strengthen that team, predominantly around primary care and working with patients and the public around expectations and understanding of the changes in primary care, but also to support practices in how they do that communication. So I think Hayley will be able to work with Health Watch to look at that, the outputs of that and support practices where they might need to update those websites or think about how they could represent some information. So yeah, we'll definitely be working closely on that.
Maggie?
Yeah, thank you. I know we'll come to it later on the agenda on the performance section, but really just to acknowledge, as Helen said, the huge pressure that the health services are under in Portsmouth, across Portsmouth and South East, across Hampshire and Isle of Wight, and indeed across the country. It is quite extraordinary, the pressure, all sectors, very, very difficult for our frontline staff collectively. And I think particularly within Portsmouth and South East, the number of ambulance handover delays is very much an outlying position across actually the south of England. So certainly a few weeks ago, there were actually more ambulance handovers at Portsmouth than across the whole of the southeast. So we are sitting in the middle of an extremely hot system, and therefore, the work of all our teams on this, enacting all the plans across Portsmouth South East, the more strategic things, but also the daily focus of keeping on top of patients who need to be discharged, and admission prevention, all that sort of work. But it is incredibly hot, and as Helen said, as we roll through the autumn and the winter, we can hope for the best, but we do need to be prepared for this situation worsening, and just paying real attention to all aspects of our system, all we can do in terms of primary care and keeping people resilient in terms of that, but as I say, all our work that we are doing. So this is not new, but I just felt it is important to say that up front, that we are sitting in the middle of a system that is very hot. Good news that we've got some money nationally for the second half of the year, and in a way good that we have such strong integration in Portsmouth, because that allows us, doesn't it, to do the best we possibly can with health and social care, recognising those issues. So the money is good, and we also know politically and from patients and communities, the expectations on the NHS, particularly in terms of the restoration work post-COVID, are really high. So we've got a lot that we're dealing with, and it was just really to acknowledge that, and to acknowledge that it really is impacting, rightly so, but on people's work, to make sure that we really get over this and deal with the urgent care system. Thank you.
Thank you. Anyone else? Any questions, comments for Jo? So we're being asked to note this report. People happy with that? Thank you very much. And we will move on to our system updates and start with Maggie.
Thank you. So the report you have in front of you, the same report has gone to the Hampshire, Southampton, Isle of Wight board, and this paper very deliberately pulls out the updates for CCG boards and the things that as CCG boards we need to do during these next 6 months. So a couple of things. First of all, the legislation is working its way through the committee stage, as we've reported before. So obviously all of this is subject to legislation. The second thing I wanted to say up front is this is by design the things we need to do statutorily, and of course it misses what this is all about, which is developing thriving places, highly sustainable local delivery systems, and a system across Hampshire and Isle of Wight. And the purpose of these national proposed changes are to further integrate the NHS amongst itself and to integrate with the social care, as you know. And we're in a very active period of work at the moment, which is about really designing now how we blend the integration that Joe's talked about for joint commissioning, how we get really clear about what will be done at the system level, how we confirm our clinical and professional leadership across our geographies, and how we plan for going forward. But this is the technical side of things. It's the thing that I think the board needs to be assured of, to see that we're covering all the right things, but to remind ourselves in the context of what we face operationally, this has to be proportionate to the work we've got to do, which is to get our services through these next few months. So we've got, as I say, lots of active work, and of course in Portsmouth we're in a great place because of the strong integration already and the strong work in the delivery system across Portsmouth and South East. So I think there's a massive opportunity, as board members know, to build on that work, but also to share the experiences of what's happened in Portsmouth with other parts of the geography, and to share the successes and some of the things that we've learned along the way. Because of the scale of this happening across the whole country, the programme is inevitably and appropriately so managed nationally and regionally, and just to assure everybody, I think we're connected in appropriately to all those forums, and I think that feels comfortable. The final thing to say is, in the context of our workforce who are tired, the pace of this change, obviously we have to have a real close eye to our people, the people in this board, the staff who work for the CCG, and just to make sure that they are feeling okay with the change, none the least because it's happening at a very difficult time. I think the detail here helps that. Certainly Joe, Michelle, David and I, we're keeping really close with our staff, making sure that people feel reassured, not worrying unnecessarily, but just to make sure that we do focus on that, and Joe might want to come in and say something about our staff in a minute. The final thing I wanted to say, board members will have seen much of the national guidance that is coming out. It is quite high in volume, lots of different parts of guidance, some statutory and some not. So it can be overwhelming, but I think for those of you who've read some of it, in the main, it's enabling, I think. A lot of it is sharing good practice, sharing case studies from around the country. And I think board members will feel when you read some of that, you find yourself drawn to what we've managed to achieve locally. So I think we've got to stick with the fact that the guidance is enabling. It talks about minimum things we have to do, therefore allowing us to do what is right locally. And I think it's just really important to stick with that, that this, of course, is designed for a system across the whole country. And what's important is we do what's right for us in Portsmouth, what's right for us in Hampshire and the Isle of Wight. So I'll stop there, Elizabeth, if that is okay. So Joe might want to come in and say something about our staff, and indeed other board members might want to give inputs and, of course, questions.
So Joe, do you want to say something first, and then we'll open up for questions?
Yeah, if that's okay, just to echo and support what Maggie says, and making sure that we are involved in all elements of this, and that we are then able to support our staff with this. So, as you know, Elizabeth, there's a technical board that's been set up that will oversee all of the bits of the transfer, and the HR bit is really important of that, making sure that we get that right, and that there are no data issues that could cause any problems. So that's one element of working with our teams, and our HR team, the City Council, is really hot on that and working really closely with us on that. So, but as Maggie says, it's not just about the technical transfer, although making sure everybody gets paid and there's no issues there is going to be really important, absolutely, when we make that switch. We're continuing to make sure that we are engaging with our staff using the team brief and our staff engagement forum. So we've had a couple of sessions now with teams around what do you know, what do you need to know, what are you worried about. Some FAQs have gone out on the frequently asked questions have gone out on the intranet, and we've also talked to people about what does new ways of working mean for you. And I think what we've tried to do, it can seem as if there's lots of things going on at once, whether that's the switch to the integrated care system that will replace the CCG, the integration with Health and Care Portsmouth, and the new ways of working. Are we going back to an office? What will that look like? So rather than those being three separate things, we've tried to bring them all together to say that our objective is a safe transition into the ICS that will continue to enable us to work in an integrated way across health and care, not just locally in Portsmouth, but anywhere across the Hampshire and the Isle of Wight system, and also with our partners in the acute trust. So really making our staff feel that work they're doing today is going to be valued and important moving forward, and then thinking about practically how do they do that. We know we can't go back to the offices en masse because of all the COVID restrictions that are rightly in place. So how do we make sure our staff have the IT and the skills to work in a more hybrid way using Teams, but also being able to work in other offices, other parts of the civic offices, in the hospitals trust, for example, or in offices in Winchester if we need to. So we're working all of those things through them, but using our staff engagement forum to kind of drive that and test that and make sure we have that communication alongside team briefs and alongside conversations with managers. And to support that, in early October we're having what we're calling a clear out to help out. So partly that's going out and resetting the offices, making sure we've not got anything hidden and locked in drawers that shouldn't be there, but I've been there over a year, so nothing to worry about in that sense. But it's just about making sure that we thin out the offices, but also we're using that as an opportunity to engage with teams about how they work in the future and what their priorities are. So I think that would be really helpful as well. You're on mute.
You're on mute, Elizabeth.
Daisy, sorry about that. So thank you, Joe. We've then got questions from Dave, then Margaret, and then Jackie. So Dave, do you want to start?
Thank you, Elizabeth. I just want to sort of ask a question from a provider perspective of how this is evolving. As I read these papers, I find it quite high level at the moment in trying to understand how the new system is forming. But as we go forward, and it will be very quickly towards March, April next year, I don't feel that I'm any clearer in understanding how everything will sort of look and dovetail into us as providers from next April. I think I've said before in these meetings that, as from a primary care perspective, we've enjoyed, quite a good, easy, open, good working relationship with the commissioners, and particularly with the pressures at the moment that we're all facing. As we go through this period, I think it's important that we understand how that's all going to work early so we can try and maintain that smooth transfer. And I just wondered when I might be able to feel I'm a little bit more comfortable with how that's going to look.
Maggie?
Yeah, shall I say a few things and then I'm sure others will come in. So the real focus on this, given subject to legislation, given this will happen in April, it is that we can't do huge amounts of fundamental change, but we know we're on a journey, don't we, of integration, of commissioning, moving from a very contracting procurement based thing to something that's more system. So we know we're going on that journey. Number one is to keep everybody safe, as Joe says, unashamedly, to make sure everybody's paid and the basics are covered. So at one level, I'm tempted to say, I don't think people will see a huge amount of change. People will see the people who they've worked with as a provider the normal contacts. You know, there's no reason why we would be changing the local relationships, and we continue on this journey of health and care integration in Portsmouth and our work in Portsmouth and South East with local teams, but as we've been doing over the last period, you know, with stronger links to the other geographies where that counts. So I think it'll be a real evolution. What it won't be is a brand new way of working with brand new people and brand new systems. It will just be an evolution, taking the best and accelerating that, and building together. And that's, I think that's all it can be, genuinely. And again, when you look at the national speak on things, that it has to be right for all places that are ahead of us and places that are perhaps not as developed as us. So I think we're in a good place, and we continue this journey. But as we go through these next probably 5-6 weeks, we will get clearer about how some of this stuff will actually look, David, and so that we'll begin to be clearer. David, Linda, Joe and I, lots of the leadership across Hampshire and Isle of Wight are wrestling with this. What will it look like? Where do things sit and how do they interrelate together in Portsmouth, in Southampton, in the Isle of Wight, in Hampshire? Because of course everything doesn't have to be exactly the same. So I think providers in the city and primary care in the city should in one way not notice, and anything they notice should be about better connections, less, you know, over a period of time, less of the contracting competition and more of the joint way of working. So I mean, what I would say though is I really hear the question, and equally some of the other NHS providers, some of our big trusts, they want to ask that question, and they're quite challenging of CCGs to say how a CCG is going to change, because actually as NHS providers we'd like you to change, we'd like you to do some of the good stuff, but we'd like you to change more and work with us slightly differently. So really important to keep all this dialogue open, recognise that these periods of change do cause people to be fearful, particularly, as Joe said, in the context that everybody's not together so much. So those kind of moments of making sense of the world together are just a bit more challenged, aren't they? So we just need to keep listening, keep hearing, but I think don't plan for the world to look immensely different on the 1st of April, and that together we'll work out the pace of change. But I would hope that the Portsmouth system, you know, can go faster because there's a stronger track record, you know, successes and learning the things that don't work, but hopefully with the benefit of greater integration into the city, but also greater integration with other areas where that matters. But others will come in and be able to add things.
Right. Thank you very much. We are pushing on our time, so could people please keep questions a little bit shorter and answers as brief but as necessary. So Margaret. Jackie?
The emphasis on change, sorry, which I'm coming, I'm assuming that I can come in, but
yes,
the question I had, and what was more of a question, is that I assume that the organisational design aspects of the culture change that's going to be necessary for staff, because I think at some point, although I accept that you won't see anything too different in 1st of April, we are creating a new organisation. So there will be differences, and some of those, the kind of outcomes that you want to see, given that we are focusing, because of the heat, on the kind of issues around emergency department and ambulance queues, in the next period. There's a danger that impacts negatively on community prevention, early intervention, and social care services. So how are we going to spell out our ambitions around those services in this new organisation is partly what I'm trying to articulate.
Maggie?
Yeah, I mean, I think just to say, I mean, these are the important things, aren't they? What's important, and yes, that will all be part of the work plan, the organisational design, the values, in the context of, you know, a local team in Portsmouth. So that's the important thing to say. But yeah, very helpful to hear you say all of that, and all of this has to be taken care of, as well as the more technical constitutional stuff, and really important that you know, our work plan does include that.
Thank you. Jackie?
It's really encouraging to hear what you're saying about place-based, Maggie, and the roadmap. I think you're right, doesn't give much attention to what will be happening at plays. But if I've understood you correctly, say for a lot of the current staff, they can expect to be working at a local position, if you like. That they will have a place more or less within Portsmouth, if you like. Maybe the majority of what they do would be in and around the Portsmouth, and then working at various tiers thereafter. And the other very quick one is that I've noticed as well that we've got to be clear about our language. In some places, place-based refers to Portsmouth, Fareham and South East, whereas place to me means Portsmouth. And I think we've got to be careful that we're all speaking on the same sheet, so to speak. Thank you.
I mean, you're exactly right. And on the language, it is so important. People use the word place to mean multiple things now, and I think that can cause confusion. So I think what we just have to all do is get better at saying what we mean, saying the thing, not the three-letter acronym. And of course, historically, you know, we've used this term integrated care partnership in effect to mean Portsmouth and South East. In the national guidance, ICP is now the partnership, the non-statutory part of the ICS. So you have the Integrated Care Board, which is the statutory organisation, and the ICP. So again, we don't want to be in the situation where our language is different to the national language, because we'll get in a mess. So I think, just as we do in our reports, we know there's a lot we do in the Portsmouth geography, there's a lot we do in Portsmouth and South East, and then there's the wider Hampshire and Isle of Wight. And I think if we stick with that, being clear about where do we do what and how do they interrelate, that'll get us a long way. I think the other thing that I know David is always keen to say, it's very easy during these conversations to end up saying, oh, don't worry, everything will stay exactly the same. I mean, it would be bizarre if everything stayed the same, because we're on a journey, and you know, many of our staff, yes, want to carry on working very, very locally, but of course, you know, some want the opportunity to be able to work in different spaces for a bit more experience, career enhancement, and then bring back new skills. So I think, you know, it does give us an opportunity to offer up more flexibility and more development, which some people want and some people don't. So those features are important as well.
Thank you.
Yeah, it was just to add to that really, and I guess to try and reassure the board that a lot of this is what we're doing anyway. So our teams are working very closely with teams in Portsmouth, be that the City Council or the VCA, the Hive, our voluntary sector partners, or Solent, or primary care. And we're also working in that partnership way across Portsmouth and South East Hampshire with their teams and with the Hospitals Trust. And we're also working in the ICS space as well, supporting or leading pieces of work. So I think this, as Maggie says, this should take away some of the blocks that we currently find around that way of working and help us to do that better in a way that hopefully gives us more of the outcomes. But also, absolutely, Margaret, we have to focus on the early intervention and prevention. Otherwise, we will continue to see the pressures that we're seeing at the moment. So it's really important that we have that focus too.
Thank you all very much. can we move on to David and an update for Health and Care Portsmouth, our place?
Yeah, I'm talking very much about place, that being Portsmouth. And I mean, as Maggie said, it's been both encouraging and a relief to see that as the guidance is emerging, we see that we are in line really in terms of what we're doing and our philosophy of approach to that emerging guidance. So the Thriving Places document that came out not so long ago, when we look through that, there is very little that is different really to the journey that we've been on for some time. But I have to say that part of our job as Health and Care Portsmouth is to also make sure that we all keep honest to that rhetoric in terms of the application and delivery of the changes. So that's something that we're focused on. Work we're doing at the moment. Joe's mentioned the work around the commissioning board and its revitalisation. Similarly, we're looking at the terms of reference, the parameters, and the energy really, I think, around the Health and Wellbeing Board. Because under the new regime, obviously with the CCG going, then there are fewer statutory boards around, of one of which, and particularly for place, will be the Portsmouth Health and Wellbeing Board, and we're very keen to make sure that that is absolutely fit for purpose and bundled with energy to help drive our agenda. And that is a really broad agenda as well. And I think that is one of the great things about Health and Care Portsmouth. We do take a very holistic view of the wider determinants of health, and that's reflected in the engagement within Health and Care Portsmouth. So, it's not just the usual suspects in terms of the City Council, the CCG and so forth, the hospital, but it's also our colleagues in police, our colleagues fire and rescue, the voluntary community sector, our colleagues in housing and so many other different areas. And that is something that we want to pursue, and that is something that we believe is within the spirit of the white paper and the subsequent guidance. So that's work that we're doing. And similarly, in terms of the relationship between the traditionally known commissioning side of things, like the CCG, and the providers. So, one of the things that we've been looking at, both within Health and Care Portsmouth, but also within the plenary partnership sessions that we ran, was around how do these pieces of the jigsaw fit, what alignment, what fine-tuning might be needed for the new arrangement. So that work is going on, and we are in the process of developing a follow-up session to the plenary session that many of you were involved with a couple of months ago. And once again, we will look to get some external input into that as well, because I think the voices that we heard from London, and I think it was Humberside, were very, very interesting for us, and we learnt from that experience. So that's what's going on there. And a piece of, I hope, good news is that we have been approached by the Local Government Association and by the London Borough of Kensington and Chelsea to feed into their deliberations around their integration journey. So, I think that's great. They might have asked all the places in the country, but I don't think they did. I think they did come to us because they were very interested and had heard about what we've been doing here in Portsmouth. So I think that's great. Couple of other things that we've been dealing with under the umbrella of Health and Care Portsmouth, one of which is the development regeneration issues at Cosham, where a number of public agencies, the City Council, the CCG, police, the hospital, all have an interest either in divesting of land or in using land, and that land is if carefully planned, has contiguous boundaries. So we've been successful in getting grant support from the Cabinet Office through the One Public Estate programme, and we have been effectively managing that process under the umbrella of Health and Care Portsmouth, and that's really interesting work. I guess the other thing that follows on really from what both Joe and Maggie were saying about system pressures, clearly we're acutely aware through Health and Care Portsmouth about the nature of those pressures across the wider agenda, and particularly workforce pressures. You know, we know a lot about that within health, but certainly within social care, that is also a major issue. It tends to hit the news when it manifests itself at the front door of the hospital, but actually the pressures that we are seeing now, particularly in domiciliary care, are fundamental to the operation of the whole system. But it's a bit more tangential, but we are facing similar pressures in other areas of social care as well. To the extent that those problems don't look as if they're going to go away in a hurry. Some of them are fundamental structural problems that ideally we would have started resolving 15 years ago. But I do think, never waste a good crisis. I do think that we need to reinvigorate some of our work around job design. I think, we have some areas where the traditional approach is to reduce the hours worked, reduce the wage paid, and dumb down the job. I'm absolutely not convinced of that, and it chimes in a way to something else Maggie mentioned, which was around community resilience. And I think there is an avenue for us to explore, and Health and Care Portsmouth would lend itself to that brilliantly. Is how could we pilot some initiatives to look at what, for example, would happen if we really upskilled our domiciliary care workers so that they actually became resource investigators, both for the client and within the community. How can we turn this on its head? And I think that there could be learning for other parts of the wider system in that. So that's an area that seems to be coming to the fore now, I think quite rightly. And the other is about the opportunity for us in the city to develop a multi-agency engagement and media campaign around self-help and helping, and resilience, to try to tackle some of these issues about, so which door do you aim for in terms of health and care services, but also where else is help available? And how can we help the community itself act in terms of triage without having to get people to the front door of the hospital A&E before that triage occurs. So there's a few things there going on within Health and Care Portsmouth, and I'm very pleased to say that we've still got extremely good buy-in across the whole gamut of agencies. Thank you. Happy to answer any questions.
Lovely, thank you very much, David. Some interesting stuff going on, isn't there? Any questions or comments for David? Maggie?
Yeah, I was just to really endorse what David's saying about workforce. Funding may be one thing, but workforce is, it is the fundamental issue, isn't it, for many sectors, and just our recruitment, our pipeline, our training, new roles, creating great places to work, where people get a good job and are well looked after, and these things have always been important but are just fundamental now to being able to move forward, in the context of a tough 18 months for all our frontline workers. So I guess our emphasis on our workforce and understanding it and what's happening to it, probably I would say going forward we need to spend more time on that, perhaps more than we have done historically. We tend to focus on finance, performance, quality. I think we need to add in workforce, regularly when we meet, so that we're all seeing the various aspects of workforce.
Thank you.
Sorry, I put my hand up then down, but it's to completely endorse what David has just said, actually, and Maggie, and wondering how, if we're getting this additional funding, national funding, especially, a smaller than perhaps I would have liked lump coming to social care, but how best can we use that? And that may not be a direct answer for now.
That sounds like a question for a long discussion another time.
Yeah.
If people are okay with that one, we will park that and use that perhaps in our development session to look at some of these ideas in more detail, if people are happy with that. Lovely. Thank you very much. And then Jo, have you got an update on the local system bit?
Yeah, I mean, obviously Maggie's talked a lot about the pressures that we're seeing at QA and right across the system, and we've just talked about domiciliary care pressures and also in primary care. A lot of the detail around what we're doing around that is included in the finance and performance report. So I don't know if you want me to talk about it now, or if it would be better to talk about it there under that section.
Shall we move it into the performance report section? I think that would be best.
Yeah, and I can outline all the work that we're doing in the rapid improvement plan around urgent care.
That would be lovely. Okay, so let's move on to the finance and performance reports now.
Elizabeth, would you like to do the performance before finance then, otherwise we're going to be a bit staccato, aren't we?
We are. So that would, yes. Yes. Okay. So do the performance, and that's Bernie.
Yeah, Bernie.
Bernie and Jo do a double act on this one then.
Thank you. Shall I set some context, Jo, and then come back into the specifics, I think, around where we are?
Yeah, that's perfect. And I'll do the urgent and emergency care rapid improvement plan bit.
Thank you. So I think that the first thing to recognise is this does tend to be a strategic report. It is a bit backward facing in terms of performance is reported kind of, June, July, August, rather than what we're all talking about a lot at the moment in terms of what's happening actually in the next hour in our system. So just to really reflect on where we are, I think, as people have alluded to, we do have some areas of strong performance, PHU and how we support them and their care that they provide on the elective recovery plan and delivery of elective care, and our cancer performance continue to be very strong. And so I think, just to balance out some of those conversations about the system being hot, it is to remember that is in the context of delivering other components of their workload. Before we move into urgent and emergency care, in terms of risk areas, I think there's perhaps a couple of areas just to flag. The first is our children and young persons mental health indicators in terms of access to services. We know that demand continues to outstrip supply, and we have long waiting times for our children and young people trying to access those services. And that we continue also to struggle to get take up in terms of access to psychological treatment as well. The other one I'd probably just like to flag, and it's almost a bit of a chicken and egg type scenario, is that we are struggling to see the increase and recovery of our national screening programmes and our participation in our screening programmes. They are slowly regaining their momentum, but again, in terms of supporting, front door services, one way to prevent care from becoming an emergency is the proactive screening of patients earlier in their conditions, and I think that is a component that will continue to rise up the agenda to see what we can do preemptively to provide that. People and leadership, I just wanted to flag in terms of that. Our workforce is our most important asset. As a team, we struggle to get good quality workforce indicators in a timely manner across the board. And just wanted to flag that we are working to close some of the gaps on that with our ICS and system colleagues, so we can present a more timely set of indicators on that. I wouldn't like you to think that they're empty because of where, you know, of efforts on our part, or indeed the work that the CCG is taking with partners to support that. And there is a significant ICS-led workforce programme that we are supporting. I wasn't going to say much more unless anybody has a specific question about what's included in the report itself, because I do think it would be helpful for us to talk about urgent and emergency care in the context of the system pressures we've raised, Joe. So I'll take questions if there are any, but happy to stop there.
Thank you very much, Bernie. Let's move straight on to Joe then, please.
Thank you. So again, just to update and acknowledging that you've got a lot of the detail in the report, but just to capture some of the highlights of that, we are working across the Portsmouth and South East Hampshire health and care system with all partners to look at what we can do to reduce the handover delays at the trust, and recognising that is that's where it sort of manifests itself, but there's issues, and it's a result of issues of pressures in demand right across the system, from domiciliary care through to 111 provision. Starting to see a slight decrease in 999 demand and conveyances to PHU, but again, we've still got a lot of people in the system and a lot of poorly people at QA. So we have a rapid improvement plan that we're working to, and we've been working with colleagues in the ICS. Oh, sorry, got a bit of feedback. I don't know if somebody might need to put themselves on mute. Sorry. Yeah, we're working with colleagues in the ICS, and as I say, and also with NHS England to look at what can we do in the immediate, short and more medium term to resolve these issues. And some of the things that we're looking at is around space in ED. In the hospital trust, we know that there is a problem in the ED department, and we've been working through a longer term plan around a large capital build for the emergency department. But again, that's quite a long term piece of work. So we've got some additional short term pieces that are being done. So there's a new modular build going up on the North Car Park with 72 bed wards, which should be open before Christmas. And again, that's around rehabilitation to ensure people don't decompensate in hospital, and linked to some of the stroke capacity requirements that we need. We've also just looking at the need for another bay closer to ED that will enable people to be managed through what we call SDEC, which is same day emergency care pathways, ambulatory care pathways. So, and what happens is when the hospital gets full, those services are closed down to put people into beds, and then people are then stuck in ED waiting, and that creates the ambulance whole delay. So if we can resolve some of that, we can manage more people in the hospital, in the right place in the hospital, and through that same day emergency care provision, so they're not going through ED and not necessarily requiring admission. So that's a really important piece that we are working with to get up and running. And there's, again, that will look at additional workforce but also restructuring some of the consultant medical hours to enable that ambulatory or same day emergency care delivery. That's one aspect. We recognise that, as I say, often the problem manifests itself, but the cause may be further upstream in the system, and we know how busy our primary care colleagues are. So we're doing a lot of work with primary care and looking at how we can support some of the virtual consultations that are now happening through eConsult in different ways, and testing how we can perhaps get outsource some of that virtual work, if you like, so that local doctors have more time to see patients and do that more complex work. So we're doing that. We're also working with our clinical assessment services across Portsmouth and South East Hampshire on a similar thing. At the moment, we know that they validate up to 70% of the lower level ambulance calls. If we can get them up to 95%, then that will significant of doing that validation with GPs that and you know, senior nurses, that will significantly reduce the number of conveyances to ED. So again, we're looking at that and how we can strengthen those services. We're also working really closely with social care services to increase provision. So again, not the longer term change to the domiciliary care workforce that David's talking about, although we absolutely are starting to look at that, but what can we do in the more shorter term? So how can we create more bridging capacity, get different providers to come in and work differently with us, but also looking at in the interim, how do we open beds? Again, the money isn't the issue, we've got the funding to support these things, it's getting the workforce into place, and that takes a little bit of time to do. And again, we're also working closely with our Health and Care Portsmouth and wider Hampshire and Isle of Wight colleagues around what can we do about those self-care messages and helping people to work to manage their own health better, and to help them to understand how to access the system, because it can be quite complicated. It's possibly got more complicated since COVID. And then the final thing is working with our UTC providers to get them to work together in a more collaborative way so that they can share some of the challenges and increase capacity that way. So that's a number of the things that we're currently doing.
Lovely, thank you very much. It's a much needed update in view of the situation we've got. Any comments or questions for Joe or Bernie? No, thank you very much. So can we go? Oh, Jackie.
Sorry, I will keep it short. I did have a number of questions, but time is pressing. That the fundamental one for me is that we just don't seem to have enough staff. What we've got are absolutely on their knees. So what is our strategy for getting more people into the system in whatever guise, be they social workers, be they GPs, be they consultants, be they healthcare assistants, be they allied health professionals? How do we get more people into the system? It's a big question, sorry.
And to be honest, it's a national question.
Yeah.
You know, this isn't, for a change, this isn't special to Portsmouth. It's not that we're being left out. So it is a national one.
I wasn't even thinking just Portsmouth. I was thinking Hampshire, Isle of Wight at that level. Even
it's across the country.
Fundamental shortage, and we just can't. We're shifting people around who are tired and exhausted without any fresh.
Yep.
Yeah. Okay.
Thank you. Sadly, that's it at the moment. Unless anyone else has got any brilliant suggestions.
I suppose it's just that we're trying everything, Elizabeth, and looking at what you do immediately next week, and more longer term solutions. And some of it has to be about changing the way we work as well, and trying to make things easier, take out some of the blockages for people so that the jobs aren't quite so difficult. So all sorts of things, from the short, immediate, tiny changes to, you know, really thinking about how could you provide domiciliary care differently, for example, and probably everything in between, and how do we attract people into Portsmouth and Hampshire without, you know, robbing Hampshire and the Isle of Wight, but how do we attract people into the area, because it's seen as a good place to work in Hampshire and the Isle of Wight.
Yeah, I will come in before Margaret, because I tell you, a conversation I had this morning, we're looking to shorten a referral. So for a GP to make a referral to community nursing, hopefully will save us filling out a form. We just send a task. And equally, that means community nursing won't have to read a form, they'll just open a task. Little bits, if we can do some little simple things, it will start to impact, and it's chipping away at things. That's the positive message. I can think of that as an example. Margaret.
My question is not unrelated to that, Elizabeth, as you might be arguing. It's about looking at what is the bureaucracy at the minute, and how can we reduce that without damaging the outcomes, because a lot of it is historical legacy stuff that probably no longer is no longer fit for purpose, or is not working in the way it was intended. So I think there might be some mileage in investing in a really good look at some of that bureaucracy and how it can be reduced for people in the job.
Wholeheartedly agree. I made a start this morning with Solent. So, right, any other comments? Can we move back then to Michelle and the finance report, please?
Elizabeth, I think Graham had a question.
He didn't when I said that, but Graham, go on.
Sorry, very quick comment. I know we're running out of time. I just think, you know, whether we're looking in domestic care, we've got a report later on about the social and emotional mental health strategy, which is looking at further posts, which I've got a suspicion it's a great concept, but we may struggle to fill the extra posts that we want to solve the issues. We're just talking about issues now. I think it comes back to something that was said earlier in the meeting, just around needing to, at the moment, we're just moving our deck chairs around to try and solve particular issues. And I think focusing on our pipeline and taking a kind of very multi-agency approach involving things like colleges and unis, but also taking a different approach to the way we recruit from a kind of singular competency basis, more to perhaps looking at have people got the values and that we're looking for, and then we'll supply a bit more of the training and input to point them in the right direction. Just having different approaches of that is obviously not a short-term winner, but I think it's kind of long-term where we need to be focusing to try and improve our overall capacity issue.
Thank you. Anyone want to come back on that? Right. Michelle and the finance, please.
Lovely. Thank you, Elizabeth. So the board papers included the month 4 finance position, which looks towards a forecast for the first 6 months, just to remind people that we're only looking at the first 6 months currently, and I'll talk a little bit about the next 6 months towards the end. So just by way of an introduction, the report in front of you is suggesting that we are on plan to achieve the surplus for the first 6 months. Pleased to say that we've secured funding to cover the hospital discharge programme costs. However, we are not going to receive as much of the elective recovery fund as we had planned. Part of that is because the independent sector has not quite resumed the level of expected elective activity that we were expecting. But on the plus side, we're therefore not spending as much with the independent sector. So we're working with them to understand whether that will improve in the second half of this financial year. So in terms of us achieving our planned surplus position, that means we'll get less elective recovery funds, but we offset that with the underperformance, and we'll utilise some contingency to cover off the remaining shortfall. And just to highlight the areas of overspend that we're obviously working on to reduce throughout the remaining part of the year where we can. Primary care prescribing, that is seeing an increase in price, not necessarily an increase in prescribed items. And we've got the issue remaining around mental health extra contractual referral placements for our clients. So we've got some very high cost clients, and again we're looking with the commissioning team to make sure that we're forecasting the costs appropriately in that particular area. And then, as I said, part of the package of guidance that we're getting also includes planning for the second half of 21-22. We're not expected to get that guidance until probably the early part of next week. We were hoping for it to arrive the end of this week, but it looks like it might be delayed a couple of days. But we understand that block payment arrangements will be expected to continue. We also understand that hospital discharge scheme and some of the COVID-19 costs will continue, but probably at a slightly lower rate. And we're working to understand what growth, etc., that Maggie mentioned earlier on in the meeting, that the system will receive to make sure that we cover off some of the expenditure profiles that we are currently working with our colleagues on to understand how we think our expenditure profile will happen throughout the next 6 months. In terms of deadlines, as I say, we're not expecting to get the guidance until next week, with an expected first submission sort of mid-November. So we'll be able to provide a fuller update at our next governing board in November. I wasn't going to say much more than that. Again, just are there any questions that people want to ask now, or you know, obviously we're happy to take questions if something isn't, you're not quite understanding things during the month as well. So thank you.
Thank you. So questions, comments for Michelle? Right. Well, thank you very much, Michelle. And I think we need to oh, Jackie, go for it.
It was just to say, if I haven't got any questions on finances, because I've already been previously updated, and I suspect that applies to quite a lot of the board. So thank you, Michelle. I feel that we've been really given information there as well.
Yeah, and just to reiterate that we're working with the teams to understand, you know, how we can cover some of the surge planning that we've been talking about, etc. as well. So, okay, thank you.
Yeah, and I just want to say thank you very much for you and your team and all the efforts that have been going on. It's when block contracts are mentioned, it makes it sound as if it's all straightforward, and we know it's not. So thank you very much indeed. We're being asked to note all these reports, so that's the finance and the performance reports. Are the board's happy to note these? And apologies.
Yes, certainly.
Lovely. So we have to apologise. Our guests have arrived for our annual general meeting, and we are running well behind, which I do apologise and is very unusual for us. However, it has been very useful discussions. We still have some more to go, so I do hope our guests can wait. And we would appreciate your patience while we finish the first part of our meeting. So, quality and safeguarding report, Karen.
Yes, thank you, Elizabeth. This is the quality and safeguarding report that we discussed at the committee in August. I'll be brief because I think it's fairly explicit. Just to say that I think you've seen this style of report. This is a new style report that we're trying to align ourselves to the ICS quality network and reporting sort of approach, so that we're not out of kilter with them, and the way in which we're reporting is recognised across the ICS. But I think you saw it last month, but it's changing slightly each month. So if I just very briefly go through it, the first section is the summary section, which talks about a number of concerns within either the alert, advise or assure framework. I think it's a slightly different framework than it's talked about within the performance, because they've got a slightly different methodology, and we're talking about whether we think there's sufficient mitigation plans around the quality issues. But the issues contained within the summary are across the ICS, so they're not just Portsmouth. They may also be Portsmouth, but they're not just Portsmouth. So something like the provider workforce, that's across the ICS, as we've already talked about. In the highlights section, so section 2, that is more local to Portsmouth, so a lot of those issues are Portsmouth. I just wanted to pull out 2 of the more positive things, because I think the report tends to be exception reporting and tends to pull out concerns, but there are a couple of things hidden within this report that, unless you're looking, you won't notice. So there was quality assurance visits carried out to the PCN vaccination centres, all 5 of them, and we got substantial assurance from those visits. So that was a positive thing that I thought was worth noting. And also there was a positive response to the PPCA staff survey that was conducted between May and June, and I thought that was worth noting as well. A lot of the other things I think we're probably quite well cited on. Section 3 goes into deep dives into a number of issues. I don't think there's anything there that the board aren't aware of? I'm just checking. Certainly the urgent and emergency care pathway we've talked about today. There's the rapid improvement plan in place. That gets a risk score of 20 on our quality risk register. So we equally are concerned about the pathway and the pressures on the system. I don't think there's anything else. The last two maternity services, the CQC came in and did a focus visit, and that's for information, and the annual mortality review for learning disability service, that's for information. Just trying to think if there's anything else. And then the last sort of 10 slides on the report are ICS, which we've left we've said as a Portsmouth Quality Committee, we were quite keen to see, but they're slides around the ICS, particularly around CQC and their reporting of services across the ICS. It's probably all worth noting.
Lovely, thank you very much, Karen. And I have to say, I found that first page of the alert, advise and assure very useful. It's but it was also, I found good that I knew about all the alerts before I did the report.
Absolutely,
so
absolutely.
I think that's a good sign. So we've got questions from Jackie. Does anyone else want to ask any questions before I go straight to Jackie? Okay, Jackie, floor is yours.
I won't take up too much of it, I promise. Don't send me this stuff. Part of it is to probably just picks up on the previous conversation, that the struggles there is at the urgent treatment centre, to the point that actually the hours are going to be shortened, opening hours are going to be shortened. Not quite sure how that works, but it's a 4-week pilot or something like that. I'm just trying to work out how it helps and what happens to those people that would normally ring.
We'll let Jo answer your question, Jackie.
Thank you.
So obviously this is about the significant staffing challenges that they've had at the UTC in St Mary's, and as we've talked already today, those staffing challenges are across the board. One of the ways we felt, if we could allow them to reduce to a 12-hour shift in the short term over the summer, that would help stabilise the activity there, because what we were seeing is they were struggling to accommodate all of their requirements, including how they're open on the 111 directory of service. So it was to try and stabilise provision that was kind of deteriorating on a daily basis, to stabilise it from 8 in the morning to 8 in the evening, and to redirect patients either into the GP enhanced access or out of hours service, into pharmacies to wait until the next day, or into another UTC. So we're continuing to work with them. There are those staffing challenges continue, and as I've said, we're trying to work across all 3 of our UTC providers to get them to work differently and collaboratively. And apologies for the dogs in the background, that's my daughter's just come home from school.
Thank you. And Linda, you want to
I was just going to add, Jackie, just so that the patients didn't get just sent away, there was also at the same time a pilot where the ISTC clinicians would do a triage at the front door, and if it was deemed to be suitable for primary care, would directly phone PPCA to get them put onto the PPCA system, so that they weren't just pushed away. And actually it was quite successful. There was quite a lot of people redirected back into primary care, and hopefully next time they will know to phone 111 first and get to primary care in the first place. So part of it is about educating the patients as well as they're redirected.
Yeah, and we continue to work with PPCA to explore that sort of model as well.
And I just wonder, could I just come back just a little bit, because I did notice in your previous report, Jo, you did say that, or in one of it says 69% of 111s to ED are inappropriate. So I didn't want the picture where people are literally being shuffled from one crisis point to another, and that wherever they get redirected, there is capacity for the staff to be able to help them and for people to receive the help they need.
Yeah, so that is that is a real challenge, I think, and absolutely that's why strengthening the clinical assessment service so that we get the appropriate 111 validation, because we know if people go through the CAS, they do get redirected, they do get managed in primary care. So making sure that service has capacity is really crucial. And again, it's putting all those pieces of the jigsaw puzzle together.
Thank you. And I had a very, very quick one, and it was about looked after children and the dental care, where it's saying 24% don't have a dental check.
I think it's only 24% do have a dental check. It is very low figures, and sadly this is again a national issue. The NHS dental services are really struggling. So yes, major concern. We currently do not commission NHS dental services. That's done centrally through NHS England. There are changes afoot with all the changes into ICS, but it's still a watch this space. It's a big problem.
And Elizabeth, just there's a meeting happening as we speak, actually, with my colleagues with NHS England around lack dental. It is a national issue, and I think actually ICS colleagues have been really helpful in lobbying across the system. In fact, our figures in Portsmouth they're not great, but they're even worse in Southampton and Hampshire, so it is a regional issue.
Thank you so much. Keep lobbying.
Lovely. Yes, thank you very much for that, Hayden. Okay. Thank you for that report. We're being asked to note that, and I think we've discussed it. Are people happy with it now? Thank you. So it's Hayden's turn on our children's strategy for mental health services. We've had the declarations of interest, but we've agreed from Linda and Jackie they can ask questions and discuss this. No decisions to be made. Thank you.
Okay, no problem. I'll just give you a very brief overview and then we can open it up. So this is a refresh of our social and emotional mental health strategy. Over the last sort of 3 years or so, we've moved away from a CAM strategy towards a whole system approach to mental health for children and young people, particularly in terms of getting in early and doing preventative work and early help work around mental health without relying on just long waiting times into a specialist service. The strategy has been in place in some form for about 4 years now. It's beginning to have pre-pandemic, we were certainly having an impact in terms of reducing demand for specialist CAMs, which is one of our objectives by meeting need at an earlier point. You'll be unsurprised to know that the pandemic has had a rather dramatic effect, and particularly lockdowns have had a dramatic effect on child mental health. Interestingly, it's a little bit like our work in safeguarding. It's less on the numbers, more on the complexity. So it's not that the numbers have necessarily shot through the roof, and we're experiencing the same in safeguarding services, but the complexity of need driven by lockdowns and the pandemic and schools being half closed and all those kind of things has had a significant impact on a number of children. The things that are working well, the take-up of the online digital offer, Kooth, has been really, really good, and we're extremely pleased with that. So over 400 youngsters a quarter are coming into getting that kind of support, which is really, really good. And also we've got returners. We have a number of young people that are coming back and getting support through that service. The mental health support team is being rolled out across the whole city. We're very lucky in Portsmouth. We were successful in a number of bids to ensure citywide coverage for mental health support teams. So we've got a number of specialists working within our schools, which has been a little bit tricky during the pandemic, but slowly coming back into face-to-face work to work alongside our colleagues in schools, again, to meet need, particularly around anxiety, low mood, and earlier points, and that's working successfully. We're getting there with psychiatric liaison. I wouldn't say it's particularly perfect yet, but it's beginning to work now, and particularly our work with No Limits alongside, which is a VCS organisation working alongside Solent NHS and the Hospital Trust, is beginning to bear fruit, even though again demand, particularly pandemic related, is higher than we would like to see. So generally we're quite pleased with how the strategy is going. It's not perfect. There are still some areas that we need to work on. We are trying to kind of differentiate between the issues around the quality of services, which generally are good in the city. Our JTI inspections certainly showed that our friends and colleagues in CAMS do offer a very good high quality CAMS service. So we're extremely pleased with the provider. Your pathways into services aren't always as clean as we would like them to be, or families would like them to be. So when we've mapped cases, going back to some of the points that Margaret was making around bureaucracy, you can see that in the mental health world. It's not an easy route to navigate. If your son, your daughter is experiencing mental health difficulty, it can be that it's a tricky landscape to negotiate. So we are trying to simplify. We will be simplifying those pathways. And I'm afraid the theme of the day, workforce, there's no doubt that the workforce is a significant issue. But we're delighted, obviously, that we've had investment locally within the CAM service. But following the money has to be the staff to actually deliver the service. Now, at the same time that Portsmouth CCG has invested in the local CAM service, as has Hampshire colleagues, recruiting huge numbers of posts. So we're in this really uncomfortable place of actually battling over the same small workforce. I think we've got some conversations to have with HEE about how they train and support mental health specialists. And again, taking this whole system approach, we do have to have a workforce. I often draw the parallel with safeguarding. If you go back to child protection and safeguarding 10, 15 years ago, the quality across the system was questionable in terms of child protection, whereas our social work was always very, very good. I think the confidence around mental health as a whole system approach for our practitioners in schools and other organisations possibly isn't there yet. And I think we've got some work to do on workforce to develop the skills, knowledge, competencies and confidence in particular of people to be able to talk to children and talk to families about mental health distress and put the right resources in place rather than adding them to an ever lengthening waiting list for specialist services. So we do have to do more around pathway and we do have to do more around workforce. But broadly speaking, the strategy is beginning to bear fruit. Happy to take any questions.
Lovely, thank you. Any questions? Certainly feedback I've had from patients has been great about COOS, so pleased to see the numbers are going up. So we've got Graham, then Jackie.
Thanks. Hayden, a bit more of a specific one, because obviously I take on board everything you said, and I think it's a very positive strategy. Just the strand of the strategy that is about tackling racism, I just wondered, has that come out of a specific piece of work? Because I think it's a very positive thing we should be doing, but I just wondered, have we gone to racism because we've got a particular issue as opposed to, say, LGBT issues of discrimination and access?
Thank you, Graham. That bit particularly resonates. It's particularly in reference to our wider children's plan. So this SEMH strategy is one of 6 strategies that we have to improve outcomes for children across the city. So the others will include our education strategy, our safeguarding strategy, SEND, etc. What we agreed last year when we refreshed the children's plan is there's a number of cross-cutting themes, and one of those, and kind of we wanted to make sure that we didn't have the kind of Black Lives Matters as a moment, but rather as something that we continue to embed within our thinking over a period of time. And it wasn't just a kind of 2020 thing that we were all bothered about and then we forgot and kind of carried on. So the piece of work that we're doing across the children's system is to understand the experience of children and families from different ethnic minority backgrounds in particular. We deliberately didn't want to broaden it out into a wider equalities piece. We really wanted to kind of focus very hard on, because we do get messages back from families and indeed staff around their experience of working within this field. And their experience of racism in terms of living within the city. So we're doing quite a bit of work across the piece with a number of partners to really understand the experience of our workforce, but particularly our children, our families, and really question ourselves around equity of access and the experience of children.
Thank you.
Jackie?
Sorry, it's really good to hear that, Hayden. Actually, really good to hear that. My question was around, you said something that really resonated with me around the complexity of people that are appearing in the services.
Yeah.
And my experience of it is that the early help might be excellent, and then there's this little gap where you're more complex than the early help, but you're not complex enough for CAMS.
Absolutely.
There's a lot it's not a lot, but a few can fall into that slot, and I don't know how we're going to, or does this plan hope to fill that?
Oh, absolutely, Jackie. Yeah, you're singing my song. You're absolutely right. You could be too complex for one thing and not quite complex enough for another thing. It's a bit like the old days when we used to say if only children offended, they'd actually get a worker for the youth offending team. But until they offend, we can't help them. It's that kind of madness. So absolutely, that is a gap in the tiered system. That Thrive model that's in the strategy, which is very similar to a safeguarding tiered system, is absolutely analysing that in terms of what we call that kind of upper tier 3 bit. Before you get to the point of requiring CAMS, there is undoubtedly a gap, and that's where we want our mental health support teams in particular to be filling that gap. And the conversations we're having, the national model around MHSTs isn't quite right, and we're trying to kind of just bend and twist that so that those mental health support teams working in schools can deal with a greater range of complexity and severity of mental health need, because it's almost the actual commissioning nationally has created that gap. So we're trying to stretch MHST up rather than stretch CAMS down, because we don't have the capacity in CAMS to do that. So you're absolutely spot on, Jackie. I don't disagree at all, but we've absolutely clocked that, and we've got a plan in place to sort that gap out.
And I think that's very important. My only plea would be is that for a lot of the people I see, school might be the last place they want to have a conversation about the complexity of home life, or actually,
of course,
and home might be the last place
they
want to talk about the complexity of home or the complexity of school. So
yeah, I agree with you, and it's drawing the distinction. So MHSTs is not necessarily about providing a service within the school. It's identifying the issue and then working with the youngster in the place that they feel okay to be worked with. Does that make sense? So for some children, it's okay for them to be worked with school. You're absolutely right. A lot of our older secondary age children, they don't want to be seen to be walking into that special room that's put aside in the secondary school, because that can lead to all sorts of difficult conversations with their peers. So it may be the identification and the relationship building takes place within the school, because of course this is all relational practice, isn't it? But actually the intervention can take place outside of the school.
That sounds wonderful. I really look forward to that. I'd be very much like to be part of it, but watch the space.
Love to talk to you about it, Jackie.
Thank you.
Thank you. And then we've got Andy.
Thank you, Chair. Hayden, thank you very much for a well laid out and presented report, which, whilst easy to read, makes some grim reading somewhat. Just looking at how you've defined, in Charles Dickens, it was 46% of the under 16s are growing up in poverty. Does sort of SEMH then follow through as a result of poverty that increases, or is it spread across all the wards in the city? What's the sort of layout?
Oh, that's a really interesting question. To some extent, yes, but not necessarily a perfect match. Part of the noise in the data system is around neurodiversity. Now, one of the things that we're really passionate about is we are no longer accepting that neurodiversity is a mental health condition. So this conflation of neurodiversity and mental health is not helpful. It's not right. So what we're doing is we're saying that neurodiversity is a special educational need and difficulty potentially, and there's difference and diversity around neurodiversity, and we're putting that very much in the SEND box. We've agreed with CAMS that actually the diagnostic work that takes place actually will come into a multidisciplinary ND team, which is specialised around neurodiversity, because it is not a mental health condition, although you can have mental health needs whilst also being neurodiverse. That noise in the system means that it's difficult to delineate and differentiate between mental health need versus neurodiversity. So neurodiversity does not follow poverty lines at all. There is some evidence that mental health need does. However, we've got to be very cautious around that, because if we by geographically locating services, we can miss out on some very acute mental health needs in other parts of the city. So we have that kind of universally spread offer through all of our services to make sure we don't miss out on that. What we deliberately call the strategy social and emotional mental health. There is a correlation between the deprived areas of the ward and children requiring special educational education for social and emotional mental health. So the children at our harbour school will be clustered along lines of deprivation. That is true, but that's not the same as saying that mental health need is linked to poverty.
Thank you.
Thank you very much. That's interesting stuff, isn't it? So thank you for that report. We're being asked to note it. I think we have discussed it as well, and it, as Andy said, well written and hard to read in places, but good strategy. So thank you very much. Moving swiftly on, we've got minutes of other meetings. Primary Care Commissioning Committee from May, I believe. Margaret, have you got any updates you want to mention on this, or anything particular? You're on mute.
Sorry, I think the updates, I don't have any extra updates to add. They're included in the exec report.
Thank you. So we're being asked to note these minutes. People are happy with that? Right. Well, thank you very much. Apologies for the delay. I am aware, Maggie, you need to leave shortly. We will now move into our annual general meeting, and our first item on that agenda is a reflection of 2021 from Jo.
Thank you, Elizabeth. So it's hard to reflect on a year which has been, well, just such an unprecedented year, and unlike anything most of us have encountered before. So I feel quite honoured and humbled to be asked to do this for the board today, because I genuinely don't think we can underestimate the impact that COVID-19 and the pandemic has had on all of us and our lives. And I think it's important to reflect and for me to say my thoughts are with all the people who have lost loved ones over this last year because of COVID-19. And our health and care teams have been at the forefront of the response. And despite all the challenges that we've faced, I also think it's important to reflect, recognise and feel proud of the huge amount that we have achieved over the last year. And when I think of our work over this last year, the words compassion, commitment and collaboration are the attributes that come to mind when I think about health and care in Portsmouth and also across Hampshire and the Isle of Wight ICS. It's easy to see how that's been demonstrated when we think of our partners in GP practices, in Solent NHS Trust, the Hospitals Trust, South Central Ambulance Trust, the City Council, care homes, in domiciliary care, in the Hive and in all the other voluntary services organisations in the city. When we think of all the frontline and operational teams of doctors, nurses, paramedics, therapists, social workers and health and care workers and volunteers working in all of those organisations, I don't think we can thank them enough for the compassion, commitment and collaboration they have shown throughout the pandemic. Yet I think those attributes still hold true when we think of our own team and the work the CCG has done to support partners deliver that significant service and operational change over the last year and to support the most vulnerable in our communities. We redeployed our staff into a huge range of different organisations and roles to provide that support. Into the Hive to make calls to those who were clinically extremely vulnerable and shielding to ensure they had access to food and prescriptions. To Solent and adult social care to establish the discharge hub and the new discharge unit at Harry Sotnick House to provide support to people who needed to be discharged more quickly from hospital so that the teams in QA had space to care for those who were acutely unwell. To the council to support PPE distribution to teams across the city, including care homes, and to set up testing facilities. And to the Portsmouth Primary Care Alliance and practices to set up COVID hubs and COVID at home services. Our staff went willing and quickly to help. Our quality, continuing healthcare and contracting teams have worked tirelessly with other teams across House and Care Portsmouth to support care homes and domiciliary care workers, providing infection prevention control support, enhanced healthcare and sourcing volunteers and domiciliary workers to those homes who were struggling with staff shortages. Our primary care and medicines optimisation teams have worked relentlessly to support GP practices adapt to the new ways of working required by the pandemic, including the requirement to move to total triage models in line with the national operating model and to deliver the hugely successful primary care network-led COVID-19 vaccination clinics that have worked alongside the vaccination centre at St James. Our commissioning and transformation teams have been instrumental in working with partners in setting up new delivery models and initiatives. Those I've already mentioned around the integrated discharge team and COVID at home, but also the introduction of NHS 11 First, the single GP bypass number to help SCAS reduce attendances and conveyances to QA, and to develop more innovative ways of accessing services online. And we've already talked about Keith, which is a really good example of this. We've also worked to strengthen advice and guidance services for GPs and develop new ways of working with the Acute Trust and the local independent sector services, such as St Mary's and Spire Portsmouth, to support the recovery of elective provision and to help reduce the backlogs caused by the pandemic. Our finance teams adapted quickly to set up new payment mechanisms to ensure that small independent providers were paid on time at the start of the pandemic when things were so uncertain. More recently, they've worked collaboratively with the City Council and other finance teams across the integrated care system to ensure that we've got the financial modelling and wiring right to enable us to sustain the changes we've made to services where these have got long-term value. Our planning and performance teams have worked closely with BI teams locally and again across the ITS to build complex demand and capacity models that helped us better understand the impact of COVID and how we managed our response. Our IT, HR and communications teams have helped us adapt to these new ways of working and to ensure that we kept residents and people of Portsmouth up to date with the changes we've had to make. And our business services teams has helped us to do all of these things and quite literally keep the show on the road in a way that at times has seemed effortless, but most certainly wasn't. And all of this has been achieved while we worked from home in makeshift offices, in people's bedrooms, on their dining room tables, or in unfamiliar clinical environments where people hadn't necessarily worked before ever, or not for a huge number of years. We even had some staff in the D-Day Museum for a while helping the hive. And it's all been achieved, not just working at home, but alongside the delivery of things that would be termed business as usual for the CCG. Delivery of the flu vaccination programme, longer term design and delivery of service improvements, such as community mental health service transformation plan, the plan Hayden's just talked about, quality and safeguarding delivery, the transfer of Guildhall Walk patients to new practices, and overseeing the business case development of premises moves for 2 of our bigger practices, as well as the achievement of financial balance. So I would like to take this opportunity to send a really genuine and heartfelt thank you to all of our incredible teams across Health and Care Portsmouth for the part they've played and the compassion, commitment and collaboration they have demonstrated. And I know that these attributes will continue to be at the forefront of how we work in the future as we work with partners locally and across the ICS to reimagine the way our health and care services are designed and delivered in future. Thank you.
Thank you very much, Jo. Well said. David.
Yeah, can I just comment? I think that was Jo's first State of the Nation address. And, you know, what a tour de force. I thought that was tremendous. And I know I shouldn't really say this because, you know, we're you and you're us. But from the City Council's point of view, I'd just like to just put on the record what a tremendous partner we have found, the CCG, through all of this. But, you know, and as Jo said, you know, she quite rightly went right across the spectrum in terms of the workforce, in terms of the skill sets, in terms of the contribution that people have made. And so, you know, I just really want to say a huge thank you there. And throughout that as well, I think we've continued to innovate. We've continued to push boundaries. We've continued to seek to improve services and, most importantly, improve things for our residents, our clients, our patients, depending on which hat we have on at the time, but fundamentally for the people of Portsmouth. So, you know, I just really wanted to thank Jo, because it's been quite a year for her as well. And what tremendous partners. Thank you very much.
Thank you, David. Equally well said. Right. The next bit is the statutory duty that we have to ask the board to receive the annual report and accounts. We're asked to formally note them and adopt them there has been a slight delay in issuing these, and I will let Michelle explain quite what's happened.
So hopefully you will, all the board will now have received the annual report and accounts, and Joe has done a whistle-stop tour, so well done, Joe, for that, of all the things that are contained within that annual report. As we said, we achieved financial balance, and that was after us helping the wider system out as well. So to remind people that as part of that collaboration and approach towards working more as a system, we were able to help others in that journey as well. Yes, so in terms of us publishing our accounts on our website, I believe we now have the appropriate paperwork in order to do that, because we were waiting our external auditors to finalise the value for money side of the report that they have to do. So I believe we have everything that we need now. So if everybody's content with accepting the annual report and the annual accounts, then we will have done our statutory duty for 2020 and 21.
Thank you, Michelle. Any comments, questions, or are people happy to accept? David?
Yeah, I think just as Jackie referenced on a previous item, I think I've certainly felt hugely supported through this from Michelle. We've had the opportunity to ask questions. It's gone thoroughly through our processes. I have no further questions. I'm very happy to endorse.
Thank you. Okay, lots of nods. So we are happy to accept these and adopt them. Thank you. And now, very belatedly, and I do hugely apologise to our guests from Positive Mind Service, we move on to a presentation, and this is a service that, from my perspective as a frontline GP, was a absolute godsend in that last year. It was a service that opened up just before Christmas in 2019. And so it was still a really baby service at the start of lockdown, but has been there throughout, and has really benefited my patients, and I'm quite sure many others across the city. So I will hand over now to, we've got a whole selection, and I'm not sure, is Kerry going to start or Anna? Not sure who's going to do this.
Anna's going to do the presentation for us.
Lovely. So I'll hand over to Anna from Positive Minds. Thank you.
Good afternoon, everybody. I'm just going to share my screen. Hoping you can all see that.
Yes, that's lovely. Thank you.
Right, good afternoon, everybody, and thank you for having me. My name is Anna Fears. I am the acting team lead at Positive Minds, and I live with my own mental health conditions. I've been under both primary and secondary care. I started my journey with Solent Mind in 2016 as a service user and went on to become a volunteer. I finally landed a role as a wellbeing advisor at Positive Minds, and I worked through the pandemic on the helpline and the remote peer support sessions. So where we began, in late December 2019 to lockdown in March 2020, we were an accessible service for over 18s in the PO1 to PO6 area struggling with their mental wellbeing. We were a walk-in service where there was no appointment needed, and we had a specialised veterans arm. What was unique about us? Well, we could offer a same-day extended conversation with a trained wellbeing advisor who had their own lived experience of a mental health condition. We gave our service user validation of their feelings. We created person-centred goal plans, follow-up goal plan reviews, and used appropriate signposting. We had some clinical support from our NHS partners, and we had MDTs where we met with A2I, Talking Change, and we had support of the Society of St James to help our service users who are struggling with substance abuse. We wanted to create a no wrong door situation where even though people may not be suitable for our service, we would not turn them away. We would either take them to an MDT or handle risk if it was present. We did some workshops. The workshops that we centred on were around anxiety, depression, assertiveness and life skills. And these really had a lot of tips and techniques. And because they were presented by people with lived experience of mental health conditions, it was a peer aspect. So people understood that we had tested and tried these techniques ourselves. We began doing some outreach. We did some great stuff with the Good Mental Health Cooperative. We attended wellbeing fairs, veterans events, and regularly attended peer sessions with the Society of St James at the Recovery Hub. Then obviously in 2020, we were hit by COVID and we had to start remote working pretty quickly. We moved from a walk-in centre to an appointment-based telephone conversation, and our workshops went straight to a Zoom platform. But we were open for business all throughout the pandemic. It took 24 hours to get ourselves set up in our own homes. All of our inbound calls were pointed to each of our mobile phones, so we did not miss a single call from a service user in the handover, which we were extremely proud of. We had to download, learn and use Teams as soon as possible. And we supported each other as peers with our own lived in mental health experiences. We understood the anxiety the nation was going through at that particular time. So we made sure that we were there supporting each other. We had to identify quickly the new need that hit us. We were supporting our most vulnerable first. We were organising food bank vouchers for people. We were signposting people and supporting people that may be a victim of domestic abuse. We were supporting other services such as the Hive, and we were connecting with new partnerships such as St Margaret's Church, Compassionately Portsmouth and Victoria Park Space. We responded pretty quickly. We had to become anxiety reduction experts. So most of our calls were people that really were struggling really hardly with the pandemic and the anxiety inducing response that was giving. So we did lots of techniques with them over the phone, grounding techniques, square breathing techniques. We also did lots of worry trees with people where it's helping them organise their worries. When people are full of that much anxiety, of course, it's difficult to see the wood through the trees. So we were helping them do that. We gave wellbeing checks. So to our most vulnerable people that needed calls, maybe once, twice a week for several weeks, we did that. We made sure that we were just contacting them, people that were alone and elderly people that didn't have any family or friends. We also handled grief. One particular lady called us just 48 hours after losing her husband, and she felt she had to keep everything together for her family. Positive Minds gave her the space to say what she wanted, not in front of her children, and we kept up wellbeing checks with her for 5 weeks. We even supported her on her first day back at work. We taught her grounding skills, and we signposted her to Butterfly's bereavement service. On her last call with us, she said that we were a lifeline and our kindness would never be forgotten. We were extremely proud of that. Solent Mind quickly launched some extra support. We had a helpline that it actually still runs, and that was fantastic. That was there out of hours for people. And we now have a Solent Mind wellbeing app, which really teaches service users how to look after their own wellbeing and how to appropriately signpost them, and how also to identify when somebody is in risk or somebody is in crisis. We also supported the peer support remote service, which run over 6-week courses covering lots of different topics for people with a lived-in mental health condition themselves. We soon realised that we had a lot of diverse service users, so what we had to do is become aware of how we could best support them. So we quickly became aware of what was available. We phoned through to lots of different places of worship. We made sure that we had a point of contact for each one. We also educated ourselves in the LGBTIQ awareness training that Mind Out offered in Brighton, and we did an excellent course with them. And we also became aware of all the faith holidays that we needed to be aware of and how to support people through that time in COVID. We moved everything over to Zoom, so that was our workshops, our training, and we gave remote appointments, which we are still doing now. Our service users really enjoy that. It's really accessible for them to come in, see somebody, which some people prefer, a telephone conversation, and of course a Zoom conversation. I think that's something that we will continue working with in the future. So just some stats for you here, guys. Pre-pandemic, we had 184 referrals. During COVID, we had 532. We had 268 people attend our workshops since June 2020. We've completed 313 goal plans. We've discharged 55 people to Talking Change and 31 have been discharged to A2I. Most of our service users are over 40. Our average age is 41, but we did see 117 people aged 25 and under, and our age ranges through COVID were from 19 right up until 88. Most common reason for referral is struggling with ongoing emotional difficulties, but as you can see, we've had lots of different reasons people come to us. We have had 27 people that cited off on their first call that they wished they were, they thought they were better off dead. So we have actually had to handle risks. That's been really important to work with our NHS partners at A2I and a crisis. So how we're evolving as a service now, we're hybrid working, we are back in the office, which is incredible, but we're also working from home to do some remote appointments. We're now offering booked appointments for people, and we will hopefully be moving forward into the future where people can come in as a drop-in as well. We are creating new workshops. We now do the Decider and 5 Ways to Wellbeing, which is our most popular course, which really homes in on how mental health really is something that the person suffering with can do something about, just with some lifestyle changes and really highlighting in what they can do to alleviate their stress. We also have a one-to-one distress action course for those that come to us in very, very high distress, and we are a third-party hate crime report service. In the future, we have a new structure. So at the moment, it's just myself and 2 senior wellbeing advisors, so we're a bit stretched at the moment, but hopefully soon we will have a service manager, 2 coordinators, 3 senior wellbeing advisors and 5 wellbeing advisors, hopefully with all lived experience. We're identifying the gaps. We have noticed, especially during COVID, there is lots of gaps for people that are too risky for Talking Change, but not quite risky enough for A2I. And it's what we can do to support those people. That's obviously really important. We're developing more support groups, starting with the first over 18s LGBTQIA plus group, which will be held here at Positive Minds, and is currently in the process of being developed. And we are working in partnership with the Harbour, which is Solent Minds' new peer service, which will be run out of hours for people in a self-defined crisis. So onwards and upwards, we are recruiting, we are developing, and we are listening. We are sending out feedback forms to all of our service users, and we are hoping to host as many focus groups to hear from our service users and what they want moving forward. Thank you very much.
Thank you. That is absolutely fascinating and very encouraging to hear. Are you happy to take questions?
Yeah.
So, Andy. I think you're on mute, Andy.
Thank you. My apologies, I did drop out of the presentation for a little bit there, so you may have already answered my question. But I've taken a keen interest in watching your social media presence, particularly on Instagram. Found it really engaging, very different. It opened up lots of opportunities for people in different situations. So firstly, can I ask how effective has your social media platforms been, and what sort of responses that got? And will you continue sort of post-pandemic to sort of use that as a primary, if it is your primary source of information flow to those who need you?
Thank you. Yeah, we've really enjoyed using our social media platform. A lot of it has come from everybody that works here. It's a collective idea. We have comms champions as well that create what you see. We have had quite a bit of a response from them actually. We like to highlight particular events in the calendar, really important things that go out to different and perhaps harder reach communities. We often advertise our workshops on social media as well, and the fact that anybody over the age of 18 that's in the city, you know, whether they're primary or secondary, they can join those workshops, and a lot of people like that, and they have phoned through to us to register in order to go on them. We will be using our social media a lot more in the future when we have a bit more staff as well. It's certainly the way forward, and using the hashtags is extremely important and extremely effective way of getting out our message.
Thank you, Anna.
Thank you.
So we've got Karen, then Karsten and Joe. Karen.
Thank you, Anna. That was a really inspiring presentation. You clearly, as a team, have a real can-do attitude, which really came across. My question really is about, you moved to the sort of remote virtual because of COVID approach, but I wanted just to explore with you about how you did support each other, because you talked about having to manage risks differently. You talked about having to approach for different things that you perhaps hadn't been approached for before. And I just wondered how you generally got support, because we're also hearing about how exhausted generally our workforce is across Portsmouth. So, you know, to hear you're so positive, just wondered how you got that support.
Thank you. Well, what we did was have daily huddles several times a day. We would have booked in appointments, and if they were really stressful calls, we would huddle with each other. Sometimes some people would be on the phone, but there would be someone of the team available that was able to listen to what that person, you know, just had to listen to. Also, daily MDTs with Talking Change were a lifeline. They were absolutely excellent, and if we needed that little bit of extra support ourselves, or if we did not know how to deal with a service user, they were approachable for us, and they were absolutely fantastic. As a staff group as well, we had a WhatsApp group together where we would send each other nice things, you know, jokes, memes, and sometimes just, you know, light-hearted stuff to just see us through. Some of us, myself included, worked at home with a baby, so sometimes it was pretty bleak on days, but it was just keeping in that contact and knowing that we weren't alone. And also, when you suffer with anxiety, depression, or whatever particular mental health, when you see the nation suddenly suffering with it, you sort of, you know, you understand it because that's just been your whole life. And then suddenly the nation's going through it. So I suppose, strangely, we all felt like perhaps we had a duty of care. But it was something we did regularly, was check in with each other and support each other.
Anna, is it okay if I just add something?
Yes, please, Sherry.
Yeah. So I'll just introduce myself. So my name's Sherry Craig. I'm the programme lead for Solent Minds. So Positive Minds is one of the services in my portfolio. So just wanted to say, as in addition to everything that Anna has mentioned, Solent Mind also have an employment assistance programme. We also encourage staff to complete wellness action plans. We have an area on the intranet called Thrive. We have weekly wellbeing lunches for staff. We've got a wellbeing working party, putting things together for that peer support for staff. So there was a whole load of stuff that came out when the pandemic hit, particularly. But I think as an organisation where we predominantly have staff who have lived experience, I think wellbeing is kind of set up in our culture to look after staff. And that's really important, because if we can't look after ourselves, we can't support other people. So there are a whole raft of options for staff outside of their team as well as within their team, but also to connect with the other teams throughout our service areas. Thank you.
Thank you. And that is really good to hear. Really, really positive stuff. Karsten?
Yes, hi there. My name is Karsten Staff. I'm a GP in Southsea. I habitually use talking change to refer patients, or at least signpost them to talking change. Now that I've heard your fantastic talk on what you offer, I mean, I knew that you were there. It's sometimes quite difficult for GPs to figure out how services differentiate themselves, and you know, I like the sort of, as it appears, a more general approach that you have to sort of firstly figure out what patients are best served with. Now, one of the things that obviously GPs they can get quite set in their ways, because obviously we like to know what's out there and continue to refer to the same place for the next 20 years. But you know, I'm joking obviously, but we do need advice on what's new and what's come out, and again, my point is, how does your service differentiate itself from talking change? I think that's sort of important to spread the message. And my question is also, how fast is your contact time? So when a service user approaches you, how quickly do you respond? Talking change, I don't want to put them down, but you know, they'd often take numerous weeks to get back to a person who's self-referred. And of course, someone who's in distress, who's anxious, etc., wants help now. You know, there's no point saying you'll be seen in or spoken to in 6 weeks. You know, it gets a bit frustrating. I assume you deal with patients, or you used to deal with patients as a walk-in. That was my experience to begin with, or pre-pandemic. Is that still the case?
Do you want me to answer that, Sherry? Yeah, okay. So really, to answer your first question, what differentiates us from talking change is really, talking change, I think, is there for people that want talking therapies. If they know what they want and they have maybe a specific event that they need to discuss, or a specific thing, then yeah, talking change would be a great signpost. I would say for GPs, if they have a patient that's struggling with their mental health and they don't know what they want, which is often the case, you don't know how to, when you first approach your mental health, you don't always know what you want. So if that's the case, then I would certainly signpost them to Positive Minds, because really what we can do is have that extended conversation with them. You know, that's a half hour, 45-minute conversation with the service user. We can identify their needs, either appropriately signpost them, take them to an MDT at Talking Change, and do a warm transfer, which is lovely for the service user because it's a seamless process. It's not like, oh, you now phone here. It's like, no, we do that. You've told us your story, and we do that on your behalf. So it's almost like advocating for them. We do have people that turn up here with high risk. We do. They're not many, you know, but we do have them. We are all trained in safeguarding, and we do all know how to react to that situation. We would telephone crisis or A2I. But yeah, as a GP, I think it would be a good idea to understand, do they want therapy or do they not know what they want? And also, if people are on the waiting list for Talking Change for sort of 6 to 8 weeks, they are welcome to come and do our workshops, which is actually a great start into understanding mental health. You know, we're looking at developing new workshops as well. One I'd like to do, which is just understanding the mental health continuum, you know, where you are on that continuum. And that sort of thing can be a really good base for a service user that's sort of just being introduced to mental health support.
If I can just add also, so yeah, well said, Anna, and I think that the Positive Minds model is different from IAPT in the sense that Positive Minds is peer support. So it's staffed by people with lived experience. So the remit for Positive Minds is to deal with low level anxiety, depression, and things like that. But as Anna's saying, we won't turn anyone away. We will connect them into other services. But yeah, I think that's the USP really, is that it's peer support.
You've convinced me, Anna. That was fantastic. Thank you.
Thank you. Can we go to Jo, then Linda and Dave?
Yeah, it's not really a question, just a quick comment and to say thank you for presentation. It's really interesting and really inspiring, I think, to hear how Positive Minds, which I remember sort of being from the concept and working with Susanna and Kerry, drawing a house on a bit of paper as to how it would work, and the whole concept of it being drop-in, and it had just got up and running just before the pandemic. And then I remember thinking, oh, what's going to happen now? But you've just, flown with that online different way of working, which I think has just been fantastic. So thank you, and thank you to all your team, really.
Thank you.
Linda?
Hi, I'm Linda, one of the GPs and clinical leader for Health and Care Portsmouth. Thank you for the presentation, really interesting, and I do refer to the service quite frequently. My question, I suppose, is you're signposting people, you're having people come in distress. You'll be ideally placed to know what the problems are in the city in terms of gaps in provision for people, where they're falling through the gaps. And I think as commissioners, we'd be really interested to know if there's anything obvious that we need to do, or if in the future you've got any ideas of where those gaps are and where people are struggling to access or are falling down, what we could do to plug that.
Yeah, I really, the biggest one that strikes me, and it strikes all of us throughout the service, is this you're not risky enough for A2I, but you're too risky for talking change. This is just something we hear constantly. A2I will not see somebody unless they are actively suicidal sometimes, and that can be quite difficult because talking change do not like people that do not like to see people that are actively self-harming. So that is a really difficult thing, and a few members of staff, including myself, have been in that gap, and that is a really unpleasant place to be. It really, really is.
Yeah. And it's something that we are discussing as a partnership at the moment, and so with Solent NHS, Solent Mind and CCG, and how we can address that through community mental health framework, etc.
Brilliant, that's great. And as I say, I'm thinking of not necessarily NHS commission services either, but if there's gaps in the voluntary sector, working with the Hive and things to see what we can develop. But it'd just be really interesting. Thank you.
Thank you.
Dave?
Thank you. And Anna, thank you, the same as everybody else. That was a really excellent presentation. I just wanted to sort of ask you a little bit about the sort of veteran arm of your organisation. I do work on a day-to-day basis in a veteran-friendly accredited GP practice, and I'm particularly interested to know, do you apply the same sort of approach with veterans that you just described to Dr. Lashaft, and how that all works, and have you actually got any veteran volunteers at the moment?
I'll let Sherry answer this one, I think, if that's okay.
So the veteran service or the veteran team was set up with Positive Minds. Sadly, the funding is coming to an end at the end of October, and we are hoping to, with the restructure for the veteran staff, to move into our wellbeing stream within Positive Minds. So that information was sent out by Andy and myself, Andy Spencer, Solent NHS, to inform the Alliance that was sadly happening. But what will be happening is that once we have done the restructure and employed further staff, all of the staff will be trained in the veteran awareness area, as well as not just veterans, but also further training in any other groups as well. So no, we don't have any volunteers. We did have staff, but as I say, the funding has come to an end. Some have sadly left us, and some will be moving into the wellbeing stream.
Okay, thank you. It's a shame, obviously, that the funding's moving away, but I'm assuming that, like anybody else, if a veteran presents himself to Positive Minds, you'll still signpost in the same way.
Absolutely, we will see anybody from the community 18 above, PO1 to PO6.
Okay, thank you.
Can I intervene just for a second there and declare a conflict of interest as I do so? But given that the Age UK in Portsmouth has now got several veteran services, there might be some mileage in teaming up and going for joint funding type applications just to sustain and ensure that
our business development director is on it. Thank you.
Thank you. Jackie?
Mine was just another big thank you, Anna. I think the work you're doing is superb, and I really mean that. In terms of filling the gap, what I do like about Portsmouth, because I work there, is that we have one of the few places where you can get affordable counselling that might just plug some of those gaps for people. So again, there might be some collaborative work to be done there, because that's where it picks up. A few of my clients are those that fall between the can't get to A to I, it's not critical enough, and can't get into talking change. If they can afford, and it is a minimal amount, that might be an option. And also for domestic abuse and sexual abuse, some of that is free for people. So it might be worth tying in with them to see if...
Thank you very much.
Thank you.
Right. I'm going to come in. You've answered one of my questions in your superb presentation, but one thing that we briefly touched on veterans as one hard to reach group, and Hayden has put in the chat about he's had fantastic feedback from care leavers who've accessed your service, and they are another pretty hard to reach group, so well done there. I'm just thinking about some of the other groups of people across the city, particularly around the homeless and the substance misuse people, and how you are managing to get to some of those groups of people and be available for them.
I'll let you go with that one, Sherry.
Thank you. So yeah, there's lots of work going on. So Society of St James were running a drop-in service, particularly for our veterans, but they were also seeing people that were coming in. So we have got a partnership with Society of St James, and that will be that drop-in will be continuing. We also reached out to the Wellbeing and Independence team at the City Council, working with Sheepa and Sadia, and linking in with, it's kind of just started kind of last year, linking in with a cross-cultural women's group as a start, to co-facilitate some of the mental health related sessions, and also let the community know about Positive Minds. And one of the things that I was working on, put a business case together for to see if we could get some money from our reserves from Solent Mind, was to extend peer support in Portsmouth, because currently you can access peer support but not in the traditional sense at Positive Minds. But what we're kind of looking at is a peer support model where anywhere in the city people can access that 18 years up, whether they've got a diagnosis or not. And part of the consultation with service users was I kind of went and spoke to the GRT, started to speak to the GRT communities, the Gypsy, Romany and Traveller community. We also spoke to the cross-cultural women's group. What the group wanted was for community leaders to be trained up to be peer supporters. So that's something that we're looking at funding for, to deliver that training, and also identify those leaders who are willing to do that. And to say that the Gypsy, Romany and Traveller community, we went to Gypsy Life, spoke to Natalie and Richard from Gypsy Life, the CEOs. What they suggested is we take a sort of quite a slow approach, because if we go in all guns blazing to that community, they'll just shut the door on us. So we need to build trust, so we're going to start that in a sort of a slow process, working with John Bashford as well. And the first bit that we're working on is delivering some training to professionals in Solent NHS and at Solent Mind. So we're just trialling a pilot, and then there'll be a plan to grow that. So what we then hope is to be able to sort of go to the communities rather than expecting the communities to come to us, and deliver those services to them in their bespoke way, in a way that meets their needs. So there is lots of work going on. Dan Warren Holland is my colleague, so Dan and I manage all of the services in Portsmouth as programme leads. Dan has some more services, bless him, but he's also in his portfolio got diversity and inclusion. So there should be job adverts going out soon for 2 part-time diversity inclusion officers, and they will be working with the communities throughout our service area in Solent Mind. So yeah, there's lots more we need to do. We need to address the health inequalities and get out to reach the underserved groups. So we've started. We're moving, but we need to do more.
I'm just blown away by your ambition and your plans already. And I've had a message that Anna, you're a breath of fresh air. We need more of you. So
well done, Anna.
Yeah, and in light of Carsten's comments about a lack of awareness amongst GPs, I wonder whether you would be up for if we can get you in to a target session, Anna, because I think you would really inspire more referrals through from GP practices.
Yeah, I think that would be a really good idea.
Yeah, I'll be honoured. Thank you.
Okay, I will pass the message on to our target team, because I think your presentation today is just bang on. So thank you. Fantastic. And it's a really, really good session. So thank you so much for coming in. Kerry, you wanted to say something.
Yes, first of all to say absolutely well done, brilliant presentation, thank you guys. The other thing was that I think we have John, a service user, who was ready to talk about his I didn't want him to be left out, because bless him, he's given up his time to actually talk about how he's used the service. So it would be really lovely if he could talk to everybody and just showcase actually the support that's available.
That's wonderful. I'm sorry I hadn't noticed that. I'm so sorry.
No, don't worry. No.
So John, are you up for talking about the service?
I'm still awake. Yes, I'm here.
I hugely apologise, but thank you for being so patient and waiting for.
No, that's absolutely fine.
Hello, John.
Thank you for inviting me. I don't really know where to start, because a lot of it's already been said. I wrote loads of notes and the like, and I just might as well throw them away because I can't read my own writing now. Positive Minds. I have been previously with Talking Change in the past. I've had my issues going back with depression and anxiety for longer than I can remember now, but it's only just sort of in the last few years that I've actually recognised that there's an issue problem. I have been with Talking Change. They are very much I call it a tick box scenario, where you always feel if you ask a question or you don't quite conform with what they ask you, then we didn't ask you that, but they don't want to know exactly. It has to be spot on to for their tick boxes. With Positive Minds, now I've done all of their courses, I think, are available online. I think there are 3 or 4 of them, each extending to about 6 sessions each. But I found that they are the most relaxing type, and it was all online, admittedly, relaxing and friendly. That's the thing. You're talking to Anna and the rest of the team like they're your old friends. There was no mucking about. You had your joke or two, didn't I? Didn't we? But everything just clicked into place. Your first week is there, and you start off with a few little scenarios and whatever, and at the end of that, maybe an hour session, I think it was, you're left with a little bit of homework as such, which you can bring through over to the following week, and then discussing those issues. I can't recall. Anna will be able to tell you. I can't recall the individual things now. It's been weeks. But as I said, it's a gradual process, but only little tidbits. Nothing majorly. Nothing's gonna make you shut down, which is easy for me to do. If I get stressed, actually, I switch off. And each as I said, and each week you're just learning a little bit more about yourself. But the good thing about this was also that you were with other people. I mean, you're not in the same room. I mean, I think everybody that I was actually on with, or on one of them anyway, they kept their camera off, which was fine. So I don't even know who they are or haven't seen them. That didn't matter to me, but you could still hear what they had to say. And although, I mean, there are people worse off than me. I know there's people, however you look at it. But even though you have different experiences with your mental health, it all sort of leads to the same feeling. You feel you have the same feeling as the other person, even though they might have been set off by somebody else, and that is where Positive Mind comes in. They don't push you, they don't pressure you, and to be honest, I actually miss it in a way, because I know that it comes to an end, and I know I've got the skills in my head now to sort of like help. It would just be nice to go back for a few refreshers, I don't think there's anything on here I'm going to really say that I haven't already said. As I said, just no pressures, no tick boxing, relaxing and friendly, and everything was so simple to follow. Simple as that. I'm not going to waffle on anymore, because I'll just make myself look stupid. Well, any more than I already do.
And that is just so interesting to hear the different style, bearing in mind Carsten's original question around the difference between talking change and Positive Minds, and the idea that you're moving on but in small bite-sized manageable chunks.
Yeah. I mean, I slip back every so often, and I say these in particular have helped me sort of just like to refresh my memory, remind myself of, it's not just me, it's the whole world, and
it's interesting as well, you're saying you miss them. Surely you can go back, and I suppose I should be asking that of Sherry or Anna. John can turn back
I have absolutely no idea any more than that. I think they had enough of me, to be honest. I used to say, not him again.
if needed, John, then yes, you could of course come back to us. And I think that sort of, we were talking about peer support earlier and trying to get some funding for peer support expansion, and that would be part of, it was part of the model that we co-produced, was to sort of move on into peer support group to support each other, to refresh those tips and tools, to do the maintenance. Yeah.
It's from the treatment bit to maintenance.
That's right.
And how we all manage.
That's right. But I'm not giving up. I'm going to get the money.
Okay, it's been noted. Linda asked what the gaps are.
Can I just say again?
Please do, John.
I know I've already thanked them anyway, but I just want to thank them from the bottom of my heart for all the help that they have actually given me. It was so refreshing, and as I say, I hope to maybe in the not too distant future have something a little bit more to help with their schemes of things.
Wow.
Thank you, John. It was a privilege for us. Thank you.
All right, thank you.
Yeah, and thank you so much for coming and bearing with us that we've overrun so much. Waiting so patiently. I really appreciate your.
That's absolutely fine.
Fantastic. Has anyone got any questions of John? Does anyone want to quiz him further?
Good luck.
No.
Oh well, that's it then. I'm going.
You're off. Yeah, we'll sign you off now. But thank you, all of you, so much for coming. It's been, well, as I had the message, a breath of fresh air. Really appreciate it, and I'm so pleased I thought of inviting you, because this has made my day.
Thank
made
you.
A really good
Thank you all for the invite. Thank you.
Thank you, John, so much.
Yeah, thank you all very much. And at that point, I will draw our meeting to a close. And our next board meeting's on the 17th of November, and it will be streamed again. at that point. So thank you all very much, and apologies for it going on a bit, but actually that last bit was worth every minute of it.
Yeah. Thank you. Thanks, Liz.
Thank
Bye-bye.
you.
Thank you. Bye-bye.
Bye.